do all this.
Hey guys, welcome everyone. Welcome to another episode of Back to Basics. It's great to see you guys all live tonight. We are very, very lucky and feel very, very, very blessed to have Dr. Duyen Nguyen on with us tonight. And so, Doc, tell us a little bit about yourself, your practice, and sort of like your training, and then we can take it from there.
Sure. So hi everybody. It's my first time here. So I'm Dr. Duyen Nguyen. I'm a pediatric and adult allergist and immunologist. I was initially trained as a pediatrician at Texas Hospital, Baylor College of Medicine. And then I did my 2 years of fellowship to see both at Baylor College of Medicine here in Houston to see both kids and adults. I have been with Allergy and ENT Associates for the past 10 years. We have 16 different offices. We are allergists originally, but we have ENT in our practice as well. I work at Katy and Cypress, and we have 16 different offices. And
Wow.
yeah.
So most of your practices, most of your clinic is in either the Cypress location or the Katy location, correct?
My clinic is in Katy and Cypress location.
Okay.
But we have 16 different offices. It's a whole group. There's about 16, 20 physicians, allergists and ENT, and PA physician assistant. Yeah, we're the large group. We are the largest group in Houston. And the most amazing one, I think.
Good. So within the group, are there doctors who specialize in food allergies, or everybody does a bit of everything?
Actually, to be trained as an allergist, we supposed to know about food allergy. I'm pediatric trained, so I see a little bit more children for food allergy, like peanut allergy, eczema. But as an allergist, we evaluate and treat a wide range of conditions such as allergic rhinitis, chronic sinusitis, asthma, food allergy, drug, insect allergy, hives, or immunodeficiency in both adults and children. Yeah.
Okay, excellent. So this month is Asthma and Allergy Month, the month of May, and allergy is a huge topic in Houston because there are a lot of seasonal environmental allergies. But as a gastroenterologist, of course, my area of interest is food allergies. So one question patients always have for me is, are food allergies in children on the rise? Do you think, from your experience, from when you've been working, do you think there's an increase? We're seeing an increased number, or not really?
I think the prevalence has always been high in the United States, not necessarily more and more. The only thing, this hygiene hypothesis that we talk about, that likely because we become so clean. We use this stuff all the time, especially with the COVID pandemic. It's good to use it, but we have two different immune responses in our body. One is to fight infections, and the other one is called T2s. It's a part of allergy response. The hygiene hypothesis hypothesized that if you are so clean, then you don't fight the infection, so your other arms of immune system getting stronger, so you become more allergic. So yes, and so in a way it's kind of true that studies show that children in United States, they live in the rural area, they play with dirt, they play with animals, they actually less allergic than children live in the city. Even my own kids, sometimes they pick up stuff on the floor. I say it's okay, hopefully they're not being allergic.
Yes. So there's the hygiene hypothesis. And Doc, what about the time of food introduction? Does that make a difference at all in the development of true allergy?
Absolutely, yes. This is prime time, a fun, exciting time for the food allergy, because there's a lip study. This has been probably around for 4 or 5 years. It's been a while. But I remember when I just started practicing, I went to say hi to this pediatrician, and he asked me, what do you think about the peanut? He's retired now, so it's been a while. And he says, should I tell my kid to avoid the peanuts at early age? I told him, I don't think so, even though the recommendation back then is still that. I thought that it's for as a fellow, as an allergist, we already were trained that children should be eating food earlier. Um, he didn't believe me. Sure enough, 5 years later, it was
Yes.
the lip study come out and show that a lot of children in different part of the country, they're not
Yes.
allergic as much as us just because they eat peanuts at 4 months old.
Right.
So the
Right.
guideline now, children who are children who have less and have high risk, like
Okay.
eczema children, children with siblings who have eczema or egg
Uh-huh.
allergy, we
Uh-huh.
recommend to skin test those kids early on. And if they're not allergic to peanut tree nuts, then we tell them to challenge them, let them eat at
Okay.
4 months old.
Okay.
By doing that, they will become less allergic.
Okay, okay.
Yeah.
So that is really interesting that you mentioned that. And maybe, yes, we are seeing more of this because of the guidelines from probably the Pediatric Association in terms of introduction. But where I'm from, Ghana, West Africa, and the minute the child starts showing interest at the dinner table, like wanting to reach out for chicken or wanting to, we give food right away. We don't even look
Absolutely.
at the age of it's really just when the child starts showing interest. So that's interesting. Yeah. So
Yeah.
let's go back to adults for a minute. And as a gastroenterologist, I think this distinction between food allergy and food sensitivity has to be clearly defined. And this is what I keep telling my patients, no, it's not a food allergy. You don't have a food allergy. So I said, I'm bringing an expert on board. She's an allergist. She's going to tell us what is really a food allergy and what is a food sensitivity.
Yeah, so I see patients like that all the time, and I spend a lot of time to advise the patient. And I've been practicing 10 years, and I told my patient, do not do tests when it's not necessary. The clinical
Yes.
history is superior. I
Mhm.
need to get the clear history. What happened to you when you eat the food? You have abdominal pain, bloating. Do you have hives? Do you have itchies? Those kind of things is very important. So most of the patient, they present with abdominal pain, bloating, and I told them those are not immediate allergic reaction. The type of food allergy I evaluate and treated, those are the one have patient eat the food, then your body make an antibody against it called IgE. This is a redundant antibody, not a good one. You respond, for example, like vaccines, flu shot,
Okay.
COVID vaccine, your body make IgM. 3 4 weeks later, your body get the boosters and get the IgG. So IgM and IgG is a good immune response. IgE is a redundant antibodies that respond because genetically you make up for it. When we skin test patient, we look for the immediate allergic response to the foods. So without hives, itchiness, or oral itchiness when the patient eat fresh fruit, those part of the oral allergy syndrome, and we can talk a little bit about later. Without that clinical history, I told my patients that when we skin test them for food allergy, you may not have a good response. Skin tests have high false positive and false
Okay.
negative. So when
Okay.
we do the test, it doesn't match with the history, and it can be 40% false positive. What you going
Okay.
to do about it? So food sensitivity is a totally topics. It's a totally different topics. As you know, you deal with that more. You have to rule out lactose intolerance, right?
Yes.
In
Yes.
cheese and milk. That's I explain to my patient that is a problem of the sugar in the milk, not the protein. When you're allergic to food, it's the protein you're allergic to, not the sugar. Your body lost the ability to digest the sugars, that lactate enzyme that you lack in your gut. The patient can have bloating, diarrhea, very uncomfortable after you eat, but a lot of time you don't pay attention what you eat. The
Yeah.
milk can be in the cake that you don't pay attention. And you have
Correct.
bloatings probably about 12 hours later, right?
Yeah.
Celiac disease, so lactose intolerance is a perfect examples of food intolerance. Celiac
Intolerant.
disease, yeah, celiac disease, another type of the true immune response. You can call it intolerance, but it's an IgA mediated. It's another antibody mediated. When you eat the food, your IgA in your gut will attack and make you have bloody diarrhea and very uncomfortable. That's a totally different diagnosis. I know you guys scope patient for that. You get a blood test for IgA specifically for the
Yeah.
gluten. You
Yeah.
make gene testing to see patient have a
Mhm.
gene for celiac disease, but we do not do a skin test for that. Blood
Okay.
test can be done to rule out immediate food allergy.
Mhm.
Blood test we call is in vitro, not in vivo. A skin
Mhm.
test is in vivo because
I see.
put a little allergens on your skins and it will respond if you are allergic within about 10 to 20 minutes.
Okay.
When we actually send patient blood to look for the IgE. Again, let's go back to the skin, if we go back to the true allergic response.
Mhm.
IgE specifically for that food. If it's negative, then likely patient not allergic.
Mhm.
Patient with eczema, especially in children, you may run into a false positive for the test because the skin is so high because of the
Eczema.
eczema. So
Eczema.
the
Okay.
blood test can have high total IgE. So when
Okay.
they run the test through the flow cytometry, it can have make some noises. So you can have 0.3, zero point 0.5 IgE for milk. It doesn't mean anything. So you have to interpret the test based on the patient clinical history. Skin
So the
test usually is a better test than a blood test, though. Yes.
Okay. So what I'm hearing, Doc, from my perspective, just in looking at patients who have food allergies. So this is the person who's going to say, when I eat this food, I break out in hives, right?
Yeah.
I can't breathe, or I have like this burning, funny sensation in my mouth, like immediately after eating this particular food.
Yes.
And this person may be someone who already has some semblance of atopy. So maybe they are predisposed, they have maybe eczema and other atopic issues, right? So this is an immediate reaction happening. We will hear it about in patients who are allergic to shrimp, to seafood. It's an immediate reaction, right?
Absolutely.
Do you ever have, so those three ones are classic. Are there any atypical presentations of food allergy? Would you ever see like nausea, vomiting, diarrhea, immediate as the
Absolutely.
yes, as part of that immediate presentation, right?
Yeah. Yes.
Okay.
Abdominal pain, diarrhea, or even actually nausea, abdominal pain,
Mhm.
diarrhea, or the severe case, the patient can drop blood pressure. So those are anaphylaxis,
Immediate. Okay.
systemic shock, right?
Mhm.
But they can have abdominal pain and diarrhea. But then it's pretty significant. It's pretty significant. Patient don't feel well. They need to
Yeah.
be treated. They just don't have abdominal pain, and then it just go away by itself.
Yeah.
And
It's
then
like
usually the symptom,
uh-huh.
yeah, usually the symptom will go away within 24 hours after patient being treated with Benadryl. Yes.
Okay. Okay. So it's a crisis situation. It's sort of like an urgent
No,
episode.
it actually depends. When
Okay.
patient, especially even adult, depends
Mm-hmm.
how much they eat as well. If
Mm.
you so for me, when I skin test patient and they truly positive, isn't when you talk about shrimp, there's one thing I kind of interesting I want to point out. Patient who's allergic to dust mites, the dust mite proteins actually cross-react with shrimp. So they
I
look
see.
alike shrimp.
I
So
see.
a lot of adult patients that allergic to dust mites,
Mm.
over time, they're going to grow into allergic to shrimp. They tolerate shrimp all their life, but now they can start having problems with the shrimp. So yeah, so when we skin test patient that allergic to dust mites, may when they say now I couldn't tolerate shrimp, I can see the reason, the correlation.
I
But
see.
for even adult or children, some patients eat small amount and it make them to have abdominal pain. It is true. So they don't have the full anaphylaxis crisis if the amount was given just very small dose. So when I present food allergy, the diagnosis and treatment to my patients, I would say all food allergies consider life threatening. I never say you have mild or moderate or severe food allergy because the amount of food you eat play a role in how your presentation. If you eat the one shrimp, you may feel uncomfortable. Your body is
Yeah.
pretty smart. Your body tries to reject it. So some patient can have vomiting. Vomit one time or two times, no problem. But if you eat and then you vomit multiple times and you feel dizzy and you want to have a diarrhea, that's when epinephrine need to be given because that's considered the histamine start moving everywhere in your body, including your gut. Yes, yes.
That's a great example. I was telling you about my son.
Mhm.
He had we didn't know, but he had an egg allergy, and
Okay.
so we were introducing foods. Every time we gave him something with egg, he
Yeah.
would he would vomit everything right away.
That-
And after he vomited, he was fine. He
yeah.
would go back to playing, right?
Mhm.
But as it happened more frequently, as we gave more and more egg, we try to connect the dots, and finally we realize that it's egg, especially when it's like cooked egg or so. It's baked, it's different. When he
Yeah.
has something baked, he does not react. So why is it that some people will with egg allergy will react don't react when it's a baked food, like a cookie or a cake?
Absolutely. That's a interesting topic. I always explain to moms that have children with egg allergy that two different proteins in the egg. One's called ovalbumin or ovomucoid. Ovalbumin is a type of the protein in the egg that
We've lost our sound.
yes, the
Okay.
ovalbumin is the protein in the egg that when you bake, when you expose to the high temperature, 350 degree or higher, it will degrade the protein. So
Oh,
again, go back to the allergy immune response. Your body make antibody against the eggs, and when you expose to the protein of the egg and the antibody, the egg protein will bind to the antibody, the binding occur and it will bind to the mast cells with the type of white blood cell. The mast cell immediately release the histamine, cause an allergic response. So when you bake at high temperature, the ovalbumin protein was already broken down. So the binding site is already gone.
okay.
And yes, but ovomucoid is the protein in the egg that you cannot it cannot be broken down with the baking process.
Okay.
Children with ovalbumin allergy who can tolerate the baked goods tend to outgrow eggs faster than the one that allergic to ovomucoid. Yes.
I
So you actually, I can actually can order the blood tests we call
okay.
component testing for
Exactly.
ovalbumin, for ovomucoid, and then we can tell the parents if the kid's allergic to the baked goods or not.
Okay.
Sometimes when you do the blood test, you run through the flow cytometry. Again, it can have 1.3 Ku per liter of albumin. You don't know what to interpret it. The way I do in my clinic, and I found it works really well. And that's how I was trained at Texas Children's Hospital. I tell the mom to bring the muffin in the clinic, and I use a muffin and we put the little brick and we brick on the patient's skin. The kit that when we use the muffin to skin test directly on the patient's skin, and if there's no flare, no redness, or no will, then then that's likely the patient will tolerate the muffin.
I see. Will tolerate. I
Yes.
see. So this is interesting. Tell us a little bit. We've spoken about IgE blood test. We've
Mm-hmm.
spoken about the skin test. We spoke about sometimes the reliability of the skin test isn't great if somebody has eczema or skin disorder, right? There can
Right.
be some false positives and miss some as well. Tell us a little bit about this complement test that you mentioned, the one that you just mentioned,
The
the
complement?
the additional testing that you do for the specific over albumin. It
Yeah.
sounds like specific antigen testing.
Yes, yes. So those are again the blood test, you mean?
Mm-hmm.
Yeah,
Mm-hmm.
we call a component.
Components, yes.
So we do component food testing for milk, which
Mm-hmm.
is casein and whey.
Mm-hmm.
Same thing too. We there's an orders in the LabCorp or Quest. You can look for component milk testing or component egg testing. Same thing, peanut have component too. There in each protein of the food, there's several different specific antigen to specific protein. Same thing with milk. You have casein and whey. Probably you heard that, right?
Mm-hmm.
Patient with allergic to casein, they actually not they will not tolerate the baked milk. But
Okay.
patients with whey allergy, they will tolerate baked milk, like in the mountains. Yeah, so you can do the component testing for milk as well, and it's an IgE mediated blood test.
Okay.
The way I do the skin test for it, I tell the parent to bring a muffin with egg and
Mm-hmm.
or the muffin with milk in it, and I skin test the patient. When you
Okay.
skin test the patient, the brick in motion, when you put the little antigens, which is the food, on the patient's skin, and we
Mm-hmm.
have a little brick, and we don't, it's not supposed to break the skins, it's no blood. And the brick in motion, what it does, it introduces the little antigens on your skin, and your mast cells go back to your mast cells, the white blood cells that will release the histamine when they're exposed to that food. Mhm. We
Mm-hmm.
read the test within 20 minutes and we know the result right away.
Right. Okay, very good. Can you tell us a little bit about our patients that we see in gastroenterology who have eosinophilic disease? So we have patients with eosinophilic esophagitis or eosinophilic colitis, right? Uh,
Yes.
how does that pathway come about, and should we be doing IgE food allergy testing on them, or is it a different pathway altogether?
It is definitely a little different pathway.
Mhm.
So eosinophil is a type of white blood cells in your blood. It's only have about 2 to 3% components in your bloodstream. It's actually it's not a major cells in your body, and so in the eosinophilic gastrointestinal disease, like you have eosinophilic esophagitis, eosinophilic gastritis, or eosinophilic colitis, right? Those are when the eosinophil count present is pretty high on the esophagus and colon or gastric when it's not supposed to. Okay, so it's a chronic atopic, which is allergy condition that is not directly related to the IgE mediated I've been explaining. It's a different type of immune response. It's more like a delay response. Okay, the eosinophilic gastrointestinal disease has been recognized and is more recently. We actually, as you know, children had it long time ago, but maybe it was not recognized until now. When as adults start having more problem, they have hard time of swallowing because what happened is that the certain foods they ingest, and the top 8 foods also is the one causing the problem: milk, egg, wheat, peanut, tree nut, shellfish. Those are the ones that actually cause the delay inflammation, inflamed response in the lining of your esophagus, your stomach, and your colon, in a very silent way. That you don't have the full anaphylaxis reaction like I mentioned earlier, but this silent inflammation can make you have scar inflamed stage in your gut, and over time can cause scar on tissues that cause the patient to have difficulty swallowing, severe reflux symptoms, right? So for this condition, I remember when I was at Texas Hospital, that's Dr. Carla Davis. She's my mentor. She now a chief of Texas Hospital. She used to do a past testing for EOE condition for kids as well as for adults. This is probably back about 8 years ago, 10 years ago, and now the recommendation is not doing past testing because past tests we found that the false positive and the false negative is too high to accept the validity for the test.
What
So
exactly is past testing? Could you tell us,
past
everyone, a
test,
little more? Past
yeah.
testing. Tell us
So
what is
yeah,
that?
so Dr. Carla Davis and a lot of study in the past, they do past tests. They just almost like um, we have it they call it true test. A true test is a test we pass test. Dermatologists use a lot for
Mhm.
contact dermatitis, for
Okay.
gold allergy, nickel allergy. So there's a little small, just like a cloth, and then we use it. The material we put it on the patients
Mhm.
within 24 and 48 hours, and it's because it delay immune response, so we read it later. But they don't do patch tests for EOE condition anymore. I still do the prick test for eosinophilic esophagitis, even though the false positive, false negative for that's very high. It's not a perfect test. So as you know, for EOE condition, there is no perfect test regarding the
Mhm.
food allergy for this patient.
Mhm.
The
But it
elimination
is,
diet,
but it is a food allergy through a delayed pathway, right? So is this an IgG? Is this an IgG mediated pathway, or is this a different pathway?
it is not an IgE mediated pathway.
IgG, is it IgG mediated?
Let's talk about the IgG mediated. No, so when you IgG is an antibody that whenever you exposed to, your body going to respond naturally. And there's a lot of tests out there called intolerant tests or food sensitivity tests. Those are IgG. They look for IgG for the food.
Mhm.
Unfortunately, there's no validity in that test at all. If you eat the food, you're going to have IgG respond to it. So I do not recommend my patient to use that test because that FDA is not approved and it doesn't really give you more any evidence about your food allergic reaction. For the eosinophilic esophagitis condition, it is an eosinophilic immune response. It is a delay type, but it's how your eosinophil cells actually attack the food that you ingested
Mhm.
through
Mhm.
your gut. Yes.
So there's no perfect test for the eosinophilic
Yes,
gastrointestinal
unfortunately,
disease.
there's no perfect test. I do
There's no
skin test
perfect
patient and I
disease.
see some correlation, but the
Okay.
clinical history is extremely important. The patient will tell me I drink milk and I don't feel well. With that,
Mhm.
even my skin test negative, I'll tell patient just avoid it.
Stop. Okay.
Yeah.
So in children, I mean, I think for eosinophilic disease, there's some studies in terms of elimination diets in children. What do you recommend for adults who have severe eosinophilic disease, where you're not really able to pinpoint, right, where which foods they are? Maybe your test didn't really help you. Do you encourage an elimination protocol, and how much elimination would you do in terms of the eight foods, you know?
So I know, as you know, my husband is a gastroenterologist too. So I know in the GI data and also in the allergist data, the current guidelines deal the elimination diet even for adult. So
Mhm.
I have several adult patients come to my clinic. I would tell them to avoid these common food first,
Mhm.
and they should be on proton pump inhibitor. For the severe case, I know GI put patients on the swallow steroid, and it
Swallowed
yeah,
sometimes.
swallow like Pomacort. That will help, but again, it's a short-term treatment. It's not the first-line treatment for EOE. And then I would tell them to avoid the common foods, and we would introduce one at a time for about 2 to 3 weeks long to see how their symptom response.
Okay. So you
Yes.
would do, because it's a delayed response, you would do food avoidance of those common ones for how long? 4 weeks? How long would you do the food
Yeah,
avoidance for?
it would be 4 to 6 weeks. That
Four to
could,
6 weeks. Yeah.
yeah, that would
And
be
then
long
bring
enough.
it back. Okay. Then bring it back slowly, one at a time.
One at
Got
a
it.
time, yes.
One at a
And
time. Okay.
again, this is part of the art in medicine here. You see other allergists, you see other gastroenterologists, they might recommend a little differently. Yeah.
Absolutely. Doc, let's go back to oral allergy syndrome, because this, I think, is an interesting one that we're all, learning more and more about, and people should be aware of what it is just to see if they have that. Could you tell us more about it and what you would do as as an allergist to test for it?
Yeah, so oral allergy syndrome is a very interesting. Basically, it is an IgE mediated allergic to food, fresh fruits, vegetables, because mainly the patient's so allergic to the tree weeds and grass pollens. So the fresh fruits or vegetable, the protein look like the tree or the weeds or grass pollens. So just apple and birch tree pollens and apples and pear, they cross react. So that's a cross reactivity concept. It means that the protein look alike. So when you eat those fresh fruit, your body get confused. Your body thought that you swallow a tons of fresh pollens.
Pollen.
Yes.
Yes.
So the antibody bind non-specifically. So when you eat the fresh fruit, your body thought you swallow the pollen, so you have oral itchiness, itchiness in your mouth, tongue tingling. But rarely, I haven't seen anybody go to anaphylaxis to those fruit. On few cases in the literature may report anaphylaxis. So those are patients truly allergic to those fruit now. But for the oral allergy syndrome, it's only itchy around the mouth. And a lot of studies show that for the mild case, I would tell patients, eat an apple pies instead of apples. Because when you cook it would degrade the proteins and patient would do well. I do recommend patient to take maybe a Zyrtec or Allegra, Claritins, an antihistamine 2 hours prior eating the fresh fruit. It may help because 2 hours is when the antihistamines peak in your body. Patient that I put on allergy shot for environmental allergy, it will help their oral allergy syndrome as well. Yes.
Okay, so you see resolution of the oral allergy syndrome because you've desensitized them to a certain
Yes.
extent.
Yes.
Okay.
Absolutely.
From that. Okay. Very interesting. Doc, I had a question for you in terms of treatment. When it comes to allergy medications, there's so much over the counter, right? And in gastroenterologists, we sometimes worry about over the counter medications. Too much Tylenol can cause liver issues. Too much NSAIDs can trigger, gastric ulcers and other things. Now, when it comes to antihistamines and things like Benadryl over the counter, Zyrtec, what do the studies show about using these long term, starting from a very young age and upwards? Do the studies in the allergy world show any negatives at all? I mean, what's your thought on that?
So the most recent study on on elderly patients with the Benadryl is a first generation antihistamine like Benadryl, and I would guess go along with hydroxyzine, which is a prescription first generation antihistamine. Prolonged use in elderly patients can lead to dementia because these are antihistamine that cross your blood-brain barrier and it make you, sleepy, and it can cause you be forgetful. Otherwise, I don't think there's any long-term study for the antihistamine that show much contraindication for children. And I know most of the antihistamine, with the literature as well as my own experience in 10 years, they pretty benign. They're very benign. They've been metabolized by your liver or kidneys and then excreted pretty quickly. So even children take it, Zyrtec, since they were little. So Zyrtec and Xyzal, those antihistamine, it can cause 25% of general population drowsiness. So even though it's a non-drowsy medication, but some patient may find themselves drowsy with Zyrtec and Xyzal. I myself felt that, and that's just because a part of your gene, you don't metabolize the medication very well,
Very well, yeah.
and it can cross your blood-brain barrier. Otherwise, antihistamine is very benign. When I treat hives, I actually put patient on 4 tablets of Zyrtec a day.
Wow.
And they
Wow.
fine.
I don't know. I don't know. I sometimes worry about the chronic use of medications every day
Absolutely.
to treat things that we can avoid. I mean, as a gastroenterologist, even with the proton pump inhibitor, we realize there's overuse, right? So there are
Yeah.
definitely certain patients where you absolutely must keep them on a PPI, proton, like Nexium, omeprazole, and whatnot. But we also realize, looking at the studies that are coming out and will continue to come out, that long-term use of some of these medications also cause their issues, like increased risk of C. diff. That's clearly been shown, increased risk of, pneumonia and stuff like that. I was just wondering whether in the world of allergy, these chronic use of antihistamines, on a child every single day for many, many years, whether there's any data. But it appears that there isn't very much, right? There isn't very
Yeah,
much data.
so like I say, dementia for the first
Yeah,
generation
old, yeah.
is the
So,
main one. Otherwise, but I always tell my patient the less medications, the better.
better,
So
yeah.
to treat allergy, number one is avoidance. You want to avoid what are you allergic to. You want to move
Exactly.
the cat and dog away if you're allergic to them. So I
Right.
encourage my patient, if financially reasonable for them, if they have time, allergy shot is the way to go. My 10 years old daughter, Sophia, she's on shot as well because she's severely allergic to oak tree. And we have this beautiful tree in Houston, right?
Yes, all over.
I put her on allergy shot. This is her second years and it going so well.
Wow.
Drops as
Yeah.
well. It's not FDA approved,
Okay.
but the data has been used extensively in Europe. And our practice offer drops, so it works pretty well. The FDA approves some tablets as well. Tablets is my tablets, grass tablets, wheat tablets. But the main one we usually give is a subcutaneous, which is allergy shot. Our practice provide a lot of protocol, cluster rush to get the patient quickly to the maintenance. And we put patient on once a month for 5 years. And it works wonderfully. So I think it's a good way to go instead of taking so much medications. Yes.
That's true. So just to close a little bit on the future of desensitization, is what is in the works in terms of the allergy world, in terms of novel treatments for desensitization? Because once a month for 5 years is kind of heavy. We see a lot of drop off by after year 1 or 2 or 3. People drop off. They don't want to do it again. They can't do it again. And then there's some limitations in terms of the sublingual immunotherapy. I don't think you can do it it's not available for all allergies, right? It's available for a select few. What's coming up in the pipeline in terms of novel treatments for allergy?
Unfortunately, there's really
Nothing.
not much. Allergy shot has been given for hundreds of years. So, and I actually heard from a friend of mine that they are some kind of injections that other private allergists give to the patient. They inject in patient lymph node the high dose of allergens, and those are not FDA approved. So our practice, we've been, we follow the guideline pretty strictly. We haven't got the drop until recently. They're not FDA approved. It's cash pay. But we mainly is a subcutaneous allergy shot. It's worked so well and it's been going on for so long. So even though I have heard that other allergists did do the injection to the
I
lymph.
haven't heard of that. Okay.
Yes, I actually kind of forgot what's it called.
Okay.
um, actually the patient had it and a week later he ended up in the hospital for COVID. So my friend texted me and asked me about that. I said, I don't think it's have any correlation to it,
Yeah.
but I am not aware of it. It's not FDA approved. So, I've been practiced for 10 years. I've been in fellowship for, 2 years prior to that. I do not think any much different in the future because the shot been going so well. You actually be surprised. Lots of my patients keep the shots because the way we do it, the hours we offer,
Okay. Flexible.
flexible. Thursday is the late day for us. A patient can come the latest like 6:40. Friday 7:30 in the morning. So it's those kind of time, and they don't have to make an appointment. They just walk in, they get the shot, and they wait 20 minutes and they go home. So it's very convenient, and also because it works. It works so well that when patients stop the shot, they don't feel good, and they will remember, and they will come back and they ask.
Yeah, because they don't want to take medications all the time. They want to be comfortable. Yes.
Yeah. My daughter, I live far, so it took me, it's a struggle for me as a mom too. I'm here taking care of my patients. My daughter, I couldn't take her to get the shot because my nanny cannot drive that far to see us. And we don't have a clinic close by to my house. So we make exceptions so she can get the shot at the pediatrician office.
Oh, I see.
Our allergist, our group do not allow to take the shot home because we actually give a pretty high dose. I have seen a lot of anaphylaxis reaction to the shots because when we formulate the valve, we give a pretty good dose so that the patient can respond well to the shots. So the efficacy would be better. The efficacy for shot about 80-85%. Not everybody respond well to the shot. So when we give a patient a high dose, we do not allow to send a shot home because of the safety for the patients, not because we give the patient a hard time. My daughter had to go to the pediatrician office to get the shot instead of get it from home, or she couldn't do it at my clinic. So kids that go to college, we actually send the shot out, and the school can give it to them. The school nurse can give it to them, and I think it's convenient for them.
So they can continue doing their shots and everything while they're away.
Yes.
Excellent. Dr. Nguyen, this was a wealth of information. I learned so much. I think one of the biggest thing I learned was, right now you want to make sure that the testing that you're doing makes sense, right? Based on your clinical presentation.
It's very important.
You don't want to waste your money doing testing that's going to be low yield or doesn't fit your particular scenario. So when we now understand who has food allergy, immediate IgE, that we should refer. If we're concerned about an oral allergy syndrome, we should definitely refer because that's a cross-reactivity issue. When it comes to intolerance, like lactose or fructose intolerance, avoiding the food is the first thing to start, right? To test to see if it works. And then when it comes to all the other types of food sensitivities, the testing on that is not really quite clear. We're not really sure how that works. That's a very different picture to even eosinophilic gastrointestinal disease, which is a different pathway. And there again, elimination may be the first step before doing anything else. So this was definitely, I hope everyone will know food allergy. It's IgE, it's immediate. It is not food sensitivity or intolerance. They are different things. One can lead to crisis and death, and the other one can be managed. It's really just symptom control. So this is really, really important. I thank you for taking your time this Thursday evening to sit and talk to our natural gut relief community. This was extremely helpful information. We hope we can bring you on again. And really, really appreciate you taking the time, Dr. Nguyen.
Absolutely. Anytime. Thank you so much for inviting me.
You're most welcome. Have a wonderful evening.
You too.
All right.
Goodbye, Vivian.